patient here in our ward from MI, some kernel of MI came to me and said, do it. I said, he's a very serious patient. His renal profile is very bad. His sugar is HbA1c is very bad. There is a case spine. He is not paraplegic. I will put on the ATT and he will be, inshallah. He said, do the operation. And Megan will die. Correct. So then the special consent, we did that and he died. So आपके दिल में जो मेरा दिल तो बहुत ही खतरनाक है जिस मरीज के बारे में मुझे कह देना कि इसको नहीं करना either he died during the operation या बाद में died. So आपने दिल की बहुत सुनी लालच नहीं करना अब मेरे पास पेशेंट अगर क्लिनिक पे आता है तो मैं उसको तीनों ऑप्शन देता हूँ देयर इज ऑप्शन एट सर्जरी बेड देयर इज ऑप्शन हियर इन द वार्ड देयर इज ऑप्शन हियर इन द प्राइवेट सारे चार्जेस बताता हूँ एंड देन ही विल आस्क यू विल डू द सर्जरी आस्क आई विल डू द सर्जरी क्योंकि उनको ये कहा जाता है कि आगे से मेरा असिस्टेंट करेंगे सो दीज आर वेरी इंपॉर्टेंट दूसरा जब हिप हम करते हैं फिजियोथेरेपिस्ट अगर मैंने गलत कर भी दिया ना मैंने काफी गलत तो जब भी डिस्लोकेशन होता है तो वो फिजियोथेरेपिस्ट पे जाती है उससे गलत सो वो पुट आउट द फिजियोथेरेपी एक्चुअली सर्जरी की होती है समथिंग रॉन्ग आपस आप जब भी जाते हैं तो मैं आपस को कहता हूं कि आपने डिस्लोकेट किया है यार उसके कोई तरीका मूवमेंट की है मरीज इतना से ज्यादा सिंपल होता है एक तो बहुत बड़े लिखे होते हैं वो बहुत ही तंग करते हैं simple reason that often we have to change either cup or something else. And I am in the office of started in Sanjivat at the same time I was at home and he was just we office we are old companion. So I will lot of things जो है ना रियल होगी क्योंकि ऑलरेडी मुझे का था इंट्राआर्टिकुलर with the knee and examination but lot of contraindication indication already told by Jaz and इधर से आगे इधर से so objective जो मुझे ने कहा था how to examine the knee examination of knee is very important and is not possible I will tell you here on the picture what is when you do on the patient, then you learn the things. Okay? The second, go to inject the different way of injecting steroid or any PRP into the knee. And to learn the post-injection case. These are all things most of the time you learn. So, a healthy G joint is a hinge joint. It's made by the thigh and shin bone. And there is a lubricant synovial fluid. 5 ml per patient may बनता है जो lubricate करता है that from synovial cell. But if it's more than 5 ml, then it is known as Athenian and synovial. Third is I can rotate, roll and glide. If you look at this patient, this is a normal knee. Normal patient can sit and squat, do all the chores of the days. And if you look at this X-ray, इसका कहाँ से चलता है? इसमें चलता है वो जी अगला. If you look at this knee, this is a normal knee. You can always get AP standing knee weight bearing X-ray of both knee, not single. So you can compare both. This is a what is this? This is a radiolation line. क्या है? क्यों नजर आ रही है radiolation line? बाकी बोन आ रही this is a cartilage. Cartilage is always radiolucent. When it starts breaking, the space will decrease. So if you get the both X-ray, weight bearing X-ray, you will see if there is a one knee has more breakage, there will decrease space on the one side. So if you sit squat and there is no pain, that's either your normal joint. In AP, you know that we do the ACL, PCL, lateral, medial, collateral, and then the cushion, medial, and lateral discus. This is a Time magazine. You can see the coming epidemic of arthritis. When you are in the middle age, there is a high chance of arthritis to everyone, and especially females. Especially females after 50. But they also, if you look, don't worry. This is a new thing, but there are a lot of things to deal with up to the knee replacement. Steroid, trapeze, modification. What is arthritis? Inflammation of the any joint known as arthritis. Most common arthritis is of knee joint. Why? These are the front tire of the car. And in female, in Pakistan, we usually squat, sit, do the work at home. There's a lot of damage to the knees. So I always, मैं अपने मरीजों को कहता हूँ, these are front tire. अगर इस पे damage होता है, that's the point. And if you don't take care of punctured tire, then it will destroy and you have to go for new tire. Most common thing is arthritis. This is age-related. Then there are inflammatory diseases, a lot of inflammatory disease, rheumatoid, juvenile, ankylosing spondylitis, and post-traumatic. Usually the post-traumatic is usually in a younger patient. The trauma, intra-aortic fracture, leading to arthritis. Other fractures are age, sex, genetics, and age. These are the previous injuries. If you look at these two joints, this is a normal joint. If you look at this is the cartilage. You can see here, this is a abnormal joint. This is a type 4 arthritis, and the bone you can see on bone from this on the arthroscopy. You see the bone from the cartilage. That means this is a type 4 arthritis. I will show you what is the classification of this arthritis. You always take the weight bearing X-ray. Actually the weight, when you stand, all the weight go on the medial side. So the joint in osteoarthritis start destroying from the medial side. But there are some things like rheumatoid arthritis, early restriction of the lateral canal, they are in valgus. Usually they are in varus. So if you look at this, the alignment is a varus, and this is a normal joint. Other joint shapes, they all, and you use the finger. Mostly common is this is a osteoarthritis, this first side. So this is also the picture from the times. If you look at the joint, there is a big cartilage here. When they start destroying, this is type 4 arthritis, destruction of all the cartilage, mottling of the cartilage, and this is a crater. When you open the knee for the knee replacement, you will see this on the medial side most of the time. Whenever there is osteoarthritis, also they affect the muscles. So patients start the weakness of the muscle, deformity शुरू हो जाती है, और have to change the modification of life is very important. This is the inflammation. When there is inflammation is usually the disease of the young patients. Rheumatoid, juvenile rheumatoid, these are younger patients. This is a very important classification of arthropedic classification for the cartilage and arthritis. If you look at this ring, you can see the cartilage and then bone. This is a cartilage, and this is the bone. 0 means nothing, normal joint. 1 means there is a softening of the cartilage. You can see the fibrillation and softening of arthroscopy. Type 2, small, less than 1.5, more than 1.5, and the 4th is when you can see the bone. That is a type 4 arthritis. When you put arthroscope, you can see the bone through the cartilage. That is a type 4 arthritis. So you classify them. जिस तरह मैंने बताया कि टाइप 3 and 4 में आपको कुछ लगाने की जरूरत नहीं है, उसमें ये hyaluronic acid नहीं है. I did a study 10 years back when they on hyaluronic acid. Only stage 1 people were either that was a placebo or something. Otherwise, type 3, 4 they don't have any benefit of these hyaluronic acid. And PRP is also most probably I never injected PRP. So now the main topic is the knee examination. as आपको सबने बताया कि look, feel, orthopedic will look, feel and move. What we look at the knee, we look first of all align the gait of the knee. Ask करते patient को चले, वो चलेगा तो क्या होगा? Pain problem emphatic gait होगी, वो ऐसे से करके चलता है. Knee is pain. Second most important thing, you look at the quadriceps. मैं जब ACL वाला पेशेंट आता है तो अगर उसका मैं quadriceps एक तरफ का देखूं तो wasting of the quadriceps. अगर आपको नहीं भी पता चलता कि wasting of quadriceps is something wrong. Then alignment में deformity में या valgus होगा या varus. मैंने आपको बताया कि varus usually in osteoarthritis, valgus वैसे भी deformity है लेकिन arthritis में valgus तब होता है when there is a rheumatoid arthritis. Because rheumatoid arthritis usually destroys the lateral filament. That is the deformity, bruising. Palpation कैसे करते हैं? आप you start palpating from the tuberosity and the joint line, and then go into the popliteal fossa, and intra-articular extract. You palpate everything. If there is any tenderness, you can feel that. Then you see the for the field. Field के दो तरीके हैं. You milk up everything, and then tap the patella. You feel the field there. पता चलता है कि पानी है, and then you match both. There is a lot of fluid here. Whenever there is a field, it's very important. I will tell you what you do with this field. Hemoptysis and a field. So there is a range of motion. Range of motion में क्या है? Normal range of motion, you everybody know, is flexion is a 130 to 150 degree. Extension 0 to 5 होती है, 0 to 10 लिखी हुई है उसमें. Patellar tracking. What is patellar tracking? You feel the, just flex it, put a weight here and flex it. The patient will have prehension if there is a lateral dislocation. And you flex it, put a hand. If there is a patellar tracking, means if there is some lateral tilt, it will dislocate. So you have to check the patellar tracking. After completion of knee, you always flex it the knee and after knee replacement. And always look at the patellar tracking. If there is a lateral dislocation, means you have to release laterally. Then specific tests हैं बहुत सारे. मैं आपको आगे pictures में समझाऊंगा. Valgus test. When you are doing the valgus test, means कि you putting that you checking the medial collection. And the varus test, you are checking the lateral. You check the extension and then at 20 degree. दोनों में check करना है. कई दफा extension में वो नहीं करता लेकिन जैसे ही आप 20 degree में करते हैं, loose. So before surgery, you must check कि मैंने कौन-कौन से इसके ligament repair करने. Then is anterior and posterior draw. Anterior draw, you know, sit on the foot and draw. That is for ACL. Posterior is a sag. Usually, patient when you do the Gynaecology test, you see the one knee is sagging behind. That means ECL. Then these are the Lachman test, tibial sag test, ethnic grinding, a McMurray test. And see these two are. One is anterior draw test. When the anterior draw test is positive and Lachman is negative, you know the Lachman test. Lachman is for both are for. It's a very important thing I'm going to tell you. Anterior draw positive and Lachman negative. Lachman is the most specific test. So we usually do when patient is anesthetized. You can hold the things very easily. Anterior draw positive when there is an anteromedial fibrous break, and posterior Lachman positive only when there is a posterolateral fiber. There are two types of fibers in it. So if both totally transaction, both tests will be positive. Anterior draw and Lachman. So you understand, if the Lachman is positive, you have to reconstruct the ACL. If anterior draw but Lachman is negative, then you can leave the patient and do the orthoscopy. This is a Lachman test, flexion, and you just कईयों की बहुत बड़ी पिटाई होती है, आप पकड़ ही नहीं सकते. उसमें फिर आपने देखना होता है कि कैसे, क्योंकि ये बड़ा मुश्किल होता है कि you put one hand above and then you just feel there is a movement on it. And usually anesthesia में ले आसानी से. These are the two tests. One is McMurray for the medial meniscus and the other one McMurray for lateral. For medial meniscus, we usually external rotate, put our finger here, and then we give a varus test and flexion extension. Your meniscus will come under your hand, and you feel a click. And the same, the other is the lateral collective meniscus. McMillan is very specific test. I usually diagnose the medial meniscus. जब भी मेरे पास पेशेंट आता है, मैंने कभी भी उस मरीज को MRI नहीं देखा कभी. I first examine और फिर उसके बाद बताता हूँ कि आपका medial meniscus भी गया हुआ, आपका ACL भी गया हुआ. उससे पेशेंट का कॉन्फिडेंस बढ़ा होता है. फिर जब आप MRI पे रिपोर्ट देखते हो उसको बताते हो ये, तो वो बड़ा खुश होता है और वो कहता है डॉक्टर ने ऐसे ही पहचान ली है MRI के बाद. So always first history and then examination, then reports. हमारी आदत होती है कि हमारे पास पेशेंट आता है, हम रिपोर्ट्स देखना शुरू हो जाते हैं. दैट्स वेरी बैड थिंग. सो ऑलवेज, और पेशेंट की आदत होती है आपके हाथ में सीधा आके एक्सरे पकड़ाएगा. ठीक है, फ्रैक्चर है तो चलो देख लो, बाकी चीज़ों में आप इंजेक्शन थेरेपी नेम्स ऑफ लॉट ऑफ थिंग्स. इट्स स्टार्टेड 50 years before. 50 साल पहले से लग रही है मस्कुलोस्केलेटल. Who can inject? This man, Mia, Bauji, Javed can't inject this. He cannot inject. Because there are people sitting in various places. इलाज बगैर ऑपरेशन के उसमें टीके इंजेक्ट करते हैं. Even there is a doctor. He have an image patient. Name is Shahzad. His name is also Shahzad. वो मुझे बड़ा बदनाम करता है. 70,000 लेके 80,000 लेके एक इमेज का फोटो रखा हुआ है और उसको इंजेक्ट करता है लोगों को, और उनसे 70-60,000 लेके वो स्टीरॉइड इतने लगाता है कि आपकी सोच है उसकी. उन्हें कहता है ये मशीन है, इसके नीचे लगाऊंगा आपको, और वो फिर लोग इम्प्रेस हो जाते हैं और वो उससे लगवाते हैं और बाद में रोते रहते हैं कि इंजेक्ट 70,000 लेके. ये ओजोन में से लोग 2-2 लाख दे के फिर वापस आए होते हैं कि डिस्क लगवाने और चीज़ें लगवाने. ओजोन आमिर साहब ने बताया कि टोटली के तो so कौन कर सकता है? ऑर्थोपेडिक, रोमाटोलॉजिस्ट, स्पोर्ट्स एंड स्पेशली जनरल प्रैक्टिशनर हु आर ट्रेन्ड इन दैट. और आप देखा होगा, मैंने फिजियोथेरेपिस्ट का तो नाम ही नहीं लिखा, बट इन 1995 चार्टर्ड फिजियोथेरेपिस्ट, वेल ट्रेन्ड फिजियोथेरेपिस्ट. 5-6 years ago there were 2 physiotherapists from London who came here and spent 5-6 weeks here and trained here. देखा, वो कहते थे कि वहाँ भी ट्रेनिंग होती है लेकिन हमें पेशेंट नहीं मिलते. ट्रेनिंग देते हैं लेकिन हमें NHS की ट्रेनिंग के बाद यू कैन गो फॉर द इंजेक्शन. ये नहीं कि ट्रेनिंग ना हो और आपको इधर उधर करो. तो चार्टर्ड फिजियोथेरेपी स्टार्टेड इन 1995 इन UK. Already started. What is corticosteroid? It is an analog of cortisol hormone. क्या करता है कि एक्टिव इन्फ्लेमेटरी होता है और बाकी उन्होंने बताया कि mediate effects on the polymorph and migration of macrophages, and the last is it also depresses the immunity of the lymphocytes. That is first investigated system में जो again 1940 में किया गया. So later on this one man 1951 USA Hollander reported the first local hydrocortisone. होता क्या है, when you inject it, जो आपका synovial cells होता है, पानी चला जाता है उसके ऊपर ये चला जाता है, वहाँ से ये फिर बाकी जो रिमेनिंग होता है सिस्टम में चला जाता है. So whenever you locally injecting, it also systemic में जाता है. So these are 3 already told you. Lonagard is a trimethoprim. इसके छोटे में होते हैं, ये पेनफुल नहीं होता ज़्यादा. जिसे टेपोमेड्रोल कहते हैं, ये इसके मोटे होते हैं, ये पेनफुल होता है थोड़ा बाद में. एंड देन सबसे कम जो लगाते हैं दैट इज हाइड्रोकॉर्टिसोन. सो लिग्नोकेन का आपको बताया कि लिग्नोकेन 1% 2% प्लेन, एंड इफ यू वांट टू मेक मोर पुट सम नॉर्मल लाइन एंड dilute it to 1%. Fian, when you know the fian, you always aspirate it and then inject. If आप fian के अंदर inject कर देंगे तो patient will be more painful. So put a pillow around that, and from the medial side, lateral side, you put your needle. I will show you कैसे. अच्छा, this is a very important slide. You must know that aseptic technique. If you start from the first, no wash, no jewelry, your hand. Wash your hands for 1 minute. With iodine, change the needle before injecting it. Why? क्यों? कि sharpness जो है ना, जब आप aspirate कर रहे हो तो उसकी sharpness खत्म हो जाती है, और जब आप नी में जाते हो उसके में तो कड़ करके जाती है, पेस्ट चीख मारता है. So if you change and maintain the sharpness of the नीडल देन यू पेशेंट विल बी नॉट शोल्डर और नी में पेन नहीं होता लेकिन बाकी कहीं पेन नहीं होता बहुत पेन होता उसका मैं तरीका बताता हूँ कैसे लगाते हैं शोल्डर और नी में पेन नहीं होता मरीज को लेकिन बाकी सारी जगहों पे पेन होता है देन यू डू नॉट टच द स्किन जब आप एकदम उसको वॉश कर लेते हैं मेक अ पॉइंट वॉश इट डोंट टच अगेन और जब आप नीडल अंदर लेके जा रहे होते हैं तो नीडल को टच नहीं करना दीज आर द सेफ्टी मैं आपको इसकी दे दूंगा दीज आर वेरी इंपॉर्टेंट टू these are the different places where you can inject suprapatellar, midpatellar and enterolateral lateral क्यों जाते हैं osteoarthritis में why medial side बंद होती है osteoarthritis होता है so आप जब medial side पे जाएंगे सीधा bone को टकराएंगे so whenever you touch the bone or any soft tissue inside the patient will cry and there's the chances of breakage of needle or something. So I always go from the lateral side and usually from the eye of the knee. That's the most easiest. लेकिन अगर मैंने aspirate करना है मैं supralateral जाऊँगा मैं supralateral उसको aspirate करूँगा अंदर aspirate किससे करना चाहिए अगर बहुत ज़्यादा पेन है put a 40 gauge pranula है ठीक है उसमें से वो ऐसे fluid खुद आना चाहिए otherwise these are the different techniques you can go from laterally and medially you put the injection. Eye of the patient, eye of the knee. Eye of the knee is very important. You flex at night, there are two eyes. So usually go from the lateral side. This is the most easiest way to put the injection into the knee. When you start, always start from this. But if there is a fear, send to the some doctor, then you learn that to tap the fear and that. If you want to put injection, always put from the lateral side and here. मैं आपको हम सिखाएंगे लीडर वाली में these are different technique lateral medial and then this ultrasound this is मेरे ख्याल इसकी ज़रूरत ही नहीं this is just waste of the time so what is the post care always if it is a sometimes is a soreness injection 24 to 48 you can icing no heat for the 72 hours complication ये आपको बता चुके हैं names of the inappropriate drug fusion cause of lesion ignored, too large dose, no regard to given to the rehabilitation, too frequent injection, drug is put into wrong, poor technique. Local side effects भी नहीं सबने बताए हैं कि most commonly local side pain हो सकता है, leukoderma type जो कि transit होते चला जाता है, infection सबसे गंदी चीज है if you put a hair injection there is a 40% of tendon rupture in athletes जब आप डालेंगे इधर इंजेक्शन आप बल्कि आपके पास आए तो उसको मना करना कि आपने यहाँ इंजेक्शन नहीं लगाना फैट एट्रोफी प्लांटर फेशियाटिस भी होती है अगर वो हो जाए तो समझो पेशेंट के लिए डिलीमा है वो फिर नहीं ठीक होता क्योंकि फैट एट्रोफी हो जाती है वो जब पाँव नीचे रखता है तो उसको पेन होता है These are the different nerve damage, needle fracture, transit extremity, great soft tissue release. आपको पहले बताया कि आपने मरीज से पहले कहना है कि आपने अपना बीपी और शुगर को कंट्रोल रखना. These are two main things which you have to tell the patient. Patient को 3-4 दिन बीपी फ्लक्चुएट करता है and शुगर ऊपर नीचे. बाकी चीजें एनाफ्लैक्सिस these are rare चीजें. Menstrual irregularity both main two things. अगर patient is diabetic and hypertensive, you have to counsel the patient before injecting this. So these are the already nodes. हाँ, नीम आर्थ्रोज जो आपका एंटीकोगुलेंट पेशेंट है उसमें सबसे खतरनाक इंजेक्शन कौन सा है? कॉर्डन. If there is a bleeding inside the spine, patient will be paraplegic. So if patient is on anticoagulation, don't inject cordon anything. It's a contraindicated, absolute contraindicated. If you want to get an INR, APTT, PTTT, if it's normal, then you can. So be careful. Intra-articulation may backfire. आपको बताया क्या हो सकता है? Look at this. If there is a septic, patient come here and lot of patients go to the amputation. One sepsis, always sepsis. Thank you. Any questions?
Thank you, sir. Now I would request Dr. Haseeb Hussain to please come on stage and tell us about practical guidelines